Recording.
Hi, my name's Adam. Today I'm going to be talking about hyperkalemia. To start us off, first we're going to review the normal physiologic role of potassium in the cell. So first, potassium is 98% of potassium is found inside your cell, intracellular, and the major pump that controls potassium influx, efflux, you've got your sodium potassium pump. Also remember that this can largely be controlled, there's a cofactor magnesium that influences that. Other things that may affect potassium in the cell are things like acid-base status. So if you have metabolic acidosis or any acidosis, you want to try and remove that acidosis. So you're going to bring acid into the cell, and then potassium gets shot out. Let's see, other factors affecting potassium, as we know, aldosterone. Right, you're running angiotensin aldosterone system affects potassium balance. We'll just write RAS. Other things, your gut GI system and how it absorbs. And last, things like beta-adrenergic receptors can cause potassium influx, as well as insulin. So going back to the physiologic role of potassium in the cell, as you know, with the Nernst equation, potassium largely determines the resting membrane potential of the cell. As far as the depolarization cascade, is that right? Is that a depolarization cascade normally goes? You've got your sodium influx causing depolarization, and then you've got and potassium essentially repolarization and restores it back to normal level. Now, when you have something like increased potassium, you're going to decrease this gradient across the cell, and that's going to raise the resting membrane potential. And that's also going to decrease the amplitude of depolarization because you've got less channels being activated. And also that's going to affect repolarization, prolonged repolarization. Also of note, when you have a higher resting membrane potential, you're essentially more inactive. Sodium inactivation gates stay closed. So you initially will, by raising your resting membrane potential, you're going to get initial increase in excitability, but over time, you're having less channels open for depolarization. So you'll end up getting weaker depolarizations and ultimately no depolarization. Now I just want to go over the role of potassium in cardiac cells. And so, as you may remember, the cardiac action potential in ventricular cells, you've got that sodium influx and that potassium efflux, and then you've got your competing potassium and calcium, and then you've got largely your potassium. And then we've got our SA nodal cells. You've got the calcium influx, potassium efflux, and then you got your IF current is the slow sodium influx. And it ultimately accounts for automaticity of the cell. So when you have hyperkalemia, just like in other cells, you're increasing your resting membrane potential, you're decreasing amplitude, and then you're going to, as far as cardiac myocytes, when you have increased extracellular potassium, it actually increases the conductance of your potassium channels. So essentially you're going to have more potassium competing with either sodium or calcium, and what that does is that prolongs repolarization. Let's see. So as far as let's see. So as far as, now let's translate this into EKG changes with hyperkalemia. So you've got your normal, or what looks like a normal P, QRS, and T. When you're going to decrease excitability, well, initially increase excitability, but over time that leads to a drop off, and you're decreasing amplitude. What ends up happening is you get a widened QRS complex and a widened PR interval. Also, you're going to end up getting peak T waves is actually the initial, the first these come second. And then over time you end up getting sinusoidal waves, which is sign of imminent cardiac, possibly VFib or asystole. Okay. So now I just want to go over some reasons why you may have hyperkalemia. The most important reason would be renal failure. When your kidneys don't work, you retain potassium. Other causes are drugs that increase potassium retention, such as potassium-sparing diuretics, ACE inhibitors, angiotensin receptor blockers, a lot of antibiotics, such as like trimethoprim and penicillin G, are some drugs that increase potassium retention. Also, something like a crushing injury to the body, you're destroying lots of cells. Cells have lots of potassium. If you destroy them, then you've got tons of potassium in the serum. As I said before, something like acidosis, hypomagnesemia can cause increase, well, basically dysfunction of the sodium-potassium pump, and that can also lead to hyperkalemia. Also, any sort of GI, scratch that. So any sort of metabolic acidosis, like DKA or something like that, can also cause hyperkalemia. Well, two more things. We just want to talk about the symptoms of hyperkalemia. As you can imagine, if your cells are not depolarizing effectively, you end up getting fatigue, weakness, ultimately paralysis, respiratory failure, and then death. Also, you can predispose to arrhythmias, and you get decreased deep tendon reflexes, nausea, vomiting, or even diarrhea. Now, last we're going to talk about a little bit about treatment. The most important thing when you start seeing EKG changes like that is to give calcium. Looks like a G, but it's a C. Because what that does is that stabilizes the cardiac myocyte cell membrane and prevents further depolarizations from occurring. Sorry, not further depolarizations, but it increases the ability of the cell to depolarize. Secondly, you want to have potassium influx into the cell because you have high serum values. Things like insulin, beta agonists like albuterol, and also you can cause some alkalosis through sodium bicarb. And then lastly, you want to chelate potassium, with potassium binder like Kayexalate. Okay. Any questions?
No.
No. Okay. Yeah. We're good.